Assalamualaikum and selamat petang kepada semua. Saya ucapkan khusus untuk partisipan yang sudi attend sesi petang untuk siri webinars by PAMSo in collaboration with MKL. So tema pada hari ini adalah berkenaan dengan digital series. Bersama saya pada petang ini adalah pengurusi PAMSo, Farid Kafa. Beliau merangkap moderator untuk petang ini. Dan kita bersama saya juga pada petang ini adalah speaker utama kita, yang the one and only Profesor Jamal Hisham Hashim. So, beliau akan membentangkan mengenai topik COVID-19 pandemic and Accelerator to New Age Workplace Risk Assessment, Health and Safety Design. Sedikit latar belakang beliau telah terlibat dalam environmental health selama hampir lebih daripada 30 tahun, dan beliau menerima PhD daripada University of Michigan hampir 30 tahun yang lepas. Sekarang beliau memegang jawatan sebagai honorary professor di Universiti Selangor, dan juga beliau merupakan managing director pada Provenue Corporations yang berhad. Jadi beliau akan membincangkan mengenai topik berkaitan dengan space yang kita occupy dari segi aspek risk dan juga punya safety. Okay. Jadi sebelum saya memulakan, saya ingin mengingatkan kami akan share di screen mengenai sign in code dan juga login access untuk Google Form bagi register attendance participant. Okay, sebentar lagi. Okay. Alright. Jadi ini adalah sign in code dan anda juga boleh scan QR code yang ditampilkan. Dalam masa yang sama kami juga akan share di chat box link untuk Google Form ni, dan anda boleh key in the sign in code. Dan in between this session kita akan pamerkan juga sign out code towards the end of this program nanti untuk complete the attendance form record. Okay. So seterusnya saya ingin menyentuh sedikit mengenai dengan architecture. So kalau kita dapat lihat dari segi analogi, kalau kita dapat lihat di gambar yang saya kongsi pada hari ini adalah mengenai stesen minyak. Satu masa dulu stesen minyak hanya berfungsi sebagai tempat untuk kita mengisi petrol kita, fuel kita. Tapi setelah melalui beberapa evolusi, Petronas ataupun stesen minyak yang lain telah berevolusi dengan menawarkan pelbagai perkhidmatan. So jadi ada antaranya menawarkan perkhidmatan makanan segera, KFC, dan juga menjual barang-barang masjid dan juga all sort of things lah. Okay. So jadi yang contoh yang paling nyata kalau kita dapat lihat dari segi stesen minyak Petronas di Setiawangsa, kita dapat lihat Petronas di sana memainkan multiple function. Jadi sesuai juga untuk saya buat perbandingan dengan area architecture. Selain daripada menawarkan basic services, architecture juga boleh untuk explore avenue untuk value added dalam skills mereka. Okay. So jadi untuk terus kepada sesi pada petang ini, saya serahkan kepada moderator kita, Chairman Arkitek Farid Kafa, untuk beliau menyampaikan sepatah dua kata dan seterusnya memulakan sesi perbincangan.
Terima kasih Cik Naim. Selamat petang, good afternoon and salam sejahtera. Saya Ahmad Farid bin Abdul Ghaffar, pengurusi Chairman of PAMSo, also known as Pertubuhan Arkitek Southern Chapter. I think today we are very happy to have Professor Dr. Jamal Hisham Hashim, despite his busy schedule, to actually share with us of similar knowledge that he is doing that related to, in a way related to digital series in the field of health safety, environmental safety. This is also in line with our this weekend, Prof. This weekend we have a World Architect Day, World Architecture Day, which is also about health, healthy, clean environment for healthy world. So I think The part that I think we would like to share today is the digital element of it, so that it will give some idea of how this digital clean environment, health, safety world are related to each other. So I think I would like to thank you also, PAMCPD KL, for giving us the opportunity to collaborate with Southern Chapter. I think this collaboration actually has been a main focus this year, because PAMSo is a very new, very small chapter. However, we have embarked in a digital series, digitalization of our program since May this year. So I think we have been consistently transforming all the webinars, event in a full digital series. So I hope all the participants will enjoy, will gain knowledge of how we actually conduct our digital webinars. On top of that, I think this Professor Jamal lecture today or talk today, I hope it will be a new knowledge for us. I think because this innovation often comes from looking at outside of our own industry. So if we're able to open our mind, I think we can learn much about how to actually digitalize our industry. And for us at the PAMSo and for a lot of other architects who have ventured into digital series, also I think this could be a ideas of how to go about it in relating it to our architectural practice. So without further ado, I think I will give it to Prof. Jamal for his talk. And I think we can keep it a casual talk, Prof. I mean, it doesn't have to be so technical. It can be coffee talk, since we are about 5 o'clock, 5:15. So just a casual discussion. And then I hope participants also will be able to ask a lot of questions. The formatting, I think that is not mentioned earlier, was we also allow for a direct interactive. So those who actually wish to speak directly, they can raise their hand. The moderator, the technical team will allow the speaker on. I think then you can ask a question directly, or you can also ask a question in the chat box that our team will pick up the question for Prof. Jamal. So Prof. Jamal, silakan. I think the stage is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And a very good evening to everyone who are here today. First and foremost, thank you to Encik Farid and his team at PAM Southern Chapter for the invitation, for me to speak on a topic that is quite close to my heart. This is the first time I'm giving a lecture to the architect fraternity. I've given lectures before to Malaysian Institute of Planners and also to Institute of Engineers Malaysia. So I'm nervous and excited to be engaging with the architects and the field of architecture, and to see how we can share experiences, and how we can integrate in terms of building a better and safer and a healthier environment for the public and also the workers population. So I'll try and share my slides. Is somebody sharing it? Oh, okay. Okay. A minute, I read it. Okay. Okay, can you see my slide?
Yes, Prof.
Yes,
Okay.
yes, Prof. Yes.
Okay, so the topic given to me this evening is on COVID-19 pandemic, an accelerator to a new age workplace risk assessment, health, safety, and design. So it's quite a mouthful. I'll try to see how much I can enlighten you on this topic. Okay. Basically, what I'll be talking about today is on the COVID-19, since the topic touches on COVID-19. So I will give you a global and national scenario on this predicament or this phenomena that is sweeping the whole world. And to address this issue, one of the most important aspects to look at is to look at the risk factors. What are the factors that drive this pandemic? And to do that, we need to employ tools which we call risk assessment. So this risk assessment is one of the tools that we employ in public health to assess the threat of health from the environment or from things that would influence our health. Okay, and my team and I developed a workplace risk assessment tool. It's still in its infancy stage, but I will share with you some of the development. And since this is a talk about architect, I would like maybe to inspire you to look at the future of workplace and home, because you are very much in the designs arena in terms of designing space, whether it's workplace or home. Okay. Now, if we look at the global scenario first, in terms of the historical development of viral infection. So what we are experiencing now is not new, and it will probably not be the last among the pandemic. So historically, if we go back to the early 20th century, 1918, 1919, we had the Spanish flu. That was a pandemic. And then more recently after that, sometime after that, we had another pandemic, which was the H1N1, which is quite recent compared to the Spanish flu. That was in 2009. That was another pandemic. And currently we are experiencing the COVID-19, 2020, 2021. So that was the three of the major pandemic that swept the world. And many do not realize that actually Spanish flu was actually similar to H1N1. And what we are experiencing now, COVID-19, is actually a variation of SARS, which hit us in 2003, but it wasn't a pandemic. So you can see this problem surfacing from time to time, recurring, and among the more common virus are the coronavirus. Is what is happening with COVID-19. And you can see that the transmission mode is through droplet infection. But recently we learned with COVID-19, it can also be transmitted through aerosol. So indoor environment become a very important media of COVID-19 transmission. Now, in terms of cases, Spanish flu infected 500 million people, 500 million. that was almost 27.8% of the world population then. Yeah? So what we are experiencing now is much milder, yeah, compared to what happened in 1918. As of 25th September, we had 231 million cases of COVID-19. In terms of deaths, the Spanish flu killed 50 million. Yeah? We are now at 4.7 million. Yeah? This may be due to the lower case fatality rate, the death rate compared to Spanish flu, which was 10% of those infected. Yeah? So what I'm trying to say is that this pandemic or the viral infection is something that will come by, from time to time, periodically. So in other words, we have to prepare ourselves for the future, yeah, in terms of designing our workplaces, our home, and things like that. Yeah? In 1918, 1919, the Spanish flu killed some 34,000, or 1% out of the 3.6 million Malayan at that time. Yeah? That was more than what we have now. We have 26,800 something deaths. So you can imagine at that time the population was only 3.6 million and it killed so many people. Yeah? Now, how does Malaysia fare with the other countries, at least our neighbors, yeah, in this region, in terms of the severity of COVID-19? Actually, unfortunately, we are at the worst state right now. Yeah, this figure is as of 25th September. You can see in terms of cases per million population, we are more than double the world average, yeah, at 66,000 and above. Yeah. Fortunately, the case fatality rate is not so high, yeah, at 1.15%, which shows that our healthcare system is performing quite diligently in terms of preventing death, even though we cannot prevent the infection. Yeah? And so we need to look at what is happening, yeah? Why we have such a high rate of infection, yeah, compared to countries like Vietnam, Cambodia. Yeah? Vietnam, for example, has a much higher population than us. Some countries are badly hit in terms of death. For example, Myanmar has a very high case fatality rate. Yeah? Fortunately, now many Malaysians has been vaccinated, and that helped in curtailing the spread of this COVID-19 infection. As you can see here, in fact, we are better off than some of the developed nations like Germany, United States, Australia, okay, in terms of infection, in terms of vaccination. So that helped reduce the spread of the infection. Yeah. You can see at the bottom there, when we started the vaccination, it was on February 24th. Yeah? And the cases rise quite steeply, yeah, in August and September. And fortunately, it's coming down now after several months after the vaccination. Yeah? So I can say that we are now probably in the recovery phase. Yeah? if you look at the daily new cases in the country, we had the highest daily cases of over 24,000 towards the end of August. And nearly 600 deaths on September 11. So both are coming down now. And what is also important is that we are no longer placing high pressure or demand on our healthcare system, because you can see the active cases has come down tremendously from a high of over 268,000 to 142,000 on October 4th. So if you ask me why this is so, well, the MCO does its job to some extent, but I believe the main work is being achieved through high vaccination rate. And if you look at some other countries like United States, if you look into the data, you can see that COVID-19 is respiking, going up again in the United States. They had a very aggressive vaccination program in the beginning, but after some time they come to a wall. They cannot go further because many Americans refuse to be vaccinated. So they are stuck at the level of 63% for those who have at least one dose of vaccination. So you can see why the cases are coming back, because they do not manage to vaccinate their population enough. So it's important that we continue to vaccinate ourselves and to convince our fellow Malaysian to be vaccinated. I know there are issues of anti-vaccine movement and all that, but we have to counter that, and provide the right information to the public. So we need to understand what are the factors that are driving the COVID-19 pandemic. Now, this virus most likely is what we call a zoonotic type of infection, in that it originates from the animal. So it is a human-animal environment interaction. So that is what interests us a lot in the environmental health field, because this is the kind of interaction we look at, the human, animal, and environment interaction. What makes it problematic is that it mutates quite fast. So you have the variant of concern, variant of interest, which keep changing, and we'll try to evade our defense, our vaccination, and so on and so forth. It is also influenced by weather. Just like any other influenza, it tends to peak in the winter month. So we in Malaysia, we are not affected by that because we have a hot climate. Actually, hot temperature and high humidity is not conducive to the transmission of a coronavirus or any influenza-like virus. Of course, population mobility, movement of people across border has increased the transmission of the disease globally. Human contact, crowding event, religious event. If you remember, the Sri Petaling cluster was one of the earliest cluster. There were, for example, even in other countries like the religious cluster in India that triggered the nationwide infection. Poor personal hygiene. This is something we Malaysian has to improve tremendously. yeah, housing and sanitation, yeah, indoor environment, poor ventilation. So maybe the architect can help in this aspect in designing a more healthy and safer indoor environment. And of course, as the country mature, we have more people who are elderly. Yeah, I heard recently there was mentioned that by 2030 there might be about 15% of our population that are considered elderly. Work environment. Lastly, work environment. Now, if you look at these 12 factors that are driving the COVID-19 pandemic, 9 out of the 12 are environment and environmental health related. Yeah? And 5 out of the 12 are building and indoor environment related factors. So that's where I think the architect can come in. Yeah. One thing we see from this COVID-19 pandemic is that it cut across various discipline and field. So not just medical and health. Yeah. The education sector are affected, the manufacturing sector are affected. So it calls for a concerted effort, yeah, a whole of society, a whole of government approach. And I've been advocating this since early January 2021. Unfortunately, things doesn't come out as I wish, yeah, because I feel that if we come together as a team, yeah, we could have done better. Yeah? So we'll see how we go forward on this. Yeah? So initially I mentioned to you about risk assessment. So we have this risk of infection and risk of death from COVID-19. So we have to employ the tool we call risk assessment, because risk assessment is a proactive and a preventive public health approach. Yeah, of course, it's easier said than done. It's not easy to implement. That means to get ahead of the virus, to anticipate, what will happen next. Yeah. Now, if we do it well, yeah, and correctly, then we should be able to institute proper risk management measures. And when we institute risk management measures, we need to communicate this risk to the stakeholders. Yeah, stakeholders meaning the employer, the workers, the public, the school children, yeah, whoever are affected by the COVID-19. Yeah? And it can be applied prospectively. That means to avoid future disaster, or retrospectively by learning what are the risk factors so that we can get out of a fail or difficult situation. For example, we had to move out of a lockdown. Yeah? So essentially when we have a lockdown, what that means is that we have failed. We have to come to terms with that, because if we institute a lockdown, that means we have failed to control the disease. But we can come out of it in a good manner if we practice good risk assessment. Yeah? Okay. Now, among the risk factor, we have what we call modifiable and non-modifiable risk factor. The one in green are the modifiable. The one in red are the non-modifiable. For example, personal risk factor. We know that people, elderly people, especially with comorbidity, are at high risk. So there's nothing much we can do. A person with diabetes, who is 65 years old, and has hypertension, and is obese and all that, maybe obesity we can do something, will experience high risk of COVID-19. But we can improve our health status by controlling our hypertension, controlling our blood sugar and things like that. Behavioral risk factor is one of the most influencing risk factor which we should have been able to control. Movement of people, mobility, SOP, adherence, and so on. The other one is environmental risk factor, how we manage our home, our workplace, our indoor environment, ventilation, sanitation, and also social risk factor, social event, business activity, how we need to conduct them. For example, it's good that, we learn now that we can, in a prayer, a Muslim prayer, we can stand apart. Before this, we always, make it a point to stand close together. But because of COVID-19, there are fatwa which has come out to say that to save life, to preserve life and to maintain health, we can do that. So these are new information that we need to learn. So we need to focus on the modifiable risk factor, even though we cannot do much about the non-modifiable risk factor. Okay. Now, what is also important is for us to maintain the bigger picture or the bird's eye view of this pandemic. Okay. So here I try to put it in one page, the progression of the disease, from the hazard itself, which is the virus, to how we respond, the dose response. We know, for example, now there are people who are super spreader who release high viral load, which make them very infectious. So we understand somewhat, but not entirely. Now, exposure assessment is very important. How we behave, whether we adhere to SOP, how the socialization that we practice and all that are very important in terms of determining our exposure. And then at the bottom there in green also is the environment. That the environment is also highly critical. And then we have the personal factors, personal factors and the social risk factors. Our dependence on foreign workers and all that, undoubtedly has fueled the pandemic somewhat. And how we manage the risk, how we manage the risk, population screening, mobility control, vaccination, and all that are working. To some extent, that's good. The vaccination is working very well. And risk communication, I think we are still failing, even though we have improved now a bit towards the end. By becoming more transparent, we are able to communicate risk better to our public. Okay. So once we have understand the risk factor, through proper risk assessment, then we can formulate a good intervention program. So you can see here, I've listed the intervention program from the highest priority to the lowest priority. Of course, lockdown, EMCO, we don't want that. We want to avoid that as much as possible. Right now, I think most countries are, even though the COVID-19 has dropped tremendously in most countries, they are still enforcing international border control. Not to close their border, but if you want to go somewhere, you have to be fully vaccinated. You have to take a test before that, and maybe you have to quarantine once you arrive there and things like that. So that will go on for quite some time. Yeah. Health education is very important. If without proper health education, we can see that once the MCO is lifted, everybody goes back to business as usual. Yeah. And then we need tools, risk assessment tool. Yeah. SOP, I think sometimes, there's overload of SOP, but we need also to teach people how to assess risk. Yeah? Personal hygiene and sanitation. I coined the word Japanization. Even before COVID-19, when we go to Japan or Korea, you can see the high level of society. How should I say it? The responsibility. You see people taking the train but wearing face masks because they are not well, because the train there can be mass transport there can be very crowded. Yeah. So indoor environment, touch surfaces, improve sanitation, and then we have also to do mass testing. Now people can do testing on their own, without having to go to a clinic or center. Yeah, vaccination. Yeah, movement control order and lockdown. That's why I say, when we have to implement MCO and lockdown, it means that we have failed the above. Yeah, we have failed the above. So this is important to note. Yeah. Our group has been quite, vocal in terms of workplace COVID transmission. Not that we are against workplaces operating, but we believe that we could do more. What we need to do is actually not to stop the economy or to freeze the economy and workplaces, but to manage them better. Yeah. For example, we started off with the essential and non-essential, but when we look at it, there are safe non-essential workplaces which could have been allowed to operate. And high-risk essential workplaces has to conform to better standard and monitoring. Yeah? If they do now, workplace problem with COVID-19 is not unique to Malaysia. Our neighbor had a very terrible experience, Singapore, but I must say they came out of it quite well. Yeah. Now, lately, what we have seen is what we call sporadic cases. Yeah. So, for example, here this table from the Ministry of Health showed that up to July 2021, there were a total of 800,000 something cases. Yeah. And most of these were sporadic cases. Yeah. 36% also were cluster related. Yeah. Then among the cluster related, of course, workplace cluster made up more than 60%. Yeah. So yes, many of the cases we are seeing now are sporadic, but that doesn't mean that they don't have an origin. Yeah, they can come from community cluster, they can come from workplace cluster. It's just that we have not been able to identify where the infection came from. Yeah, and I know that some workplace cluster were classified as community cluster. For example, in Bangi here we had cluster from some factories. Yeah, but they were confined in the apartment area and labeled as a community instead of a workplace cluster. Yeah. And as I say, this is not unique to Malaysia. Yeah. So, and what I feel is that we could have learned more actually from what happened in Singapore and what happened in other countries. For example, the European Center for Disease Prevention and Control lists out the risk factor of workplace cluster in Europe. We have not done that. We have not done a systematic approach, to understand what were the risk factor in our situation. Yeah, we know. I mean, there's issue about housing and then crowded housing and all that, but we have not done investigative attempt. We have not taken an investigative attempt. And so here the list which I think are also common to what happened in Malaysia. Close direct contact with cases, insufficient and incorrect use of PPE, working in confined and closed indoor spaces, shared office, workspace, production or sale line, meeting or training with multiple persons in the same room, shared canteen space, shared dressing or resting room, lack of hand washing facility, shared staff accommodation. That's quite obvious, for example, in Malaysia, especially among migrant workers with overcrowding and poor hygiene. We have learned about this through the media. Shared transport and social activity, staff socializing together in the community, employing workers from areas with high incident. Yeah. So there are many factors that need to be considered when it comes to workplace information. Yeah? And we have seen when we enforced the MCO, but the workplace were operating, we continue to have workplace cluster. Yeah? So again, I'm not saying that we have to stop work. That's impossible because it involves livelihood. Of course, we want to save life, but we have to also maintain livelihood. Okay? So me and my team, we start thinking there must be a way to work around this, to make our workplace safer. So that's when we come up with this COVID-19 workplace risk assessment metric. It involves a scoring process. Yeah. 1 minute.